Is Samuel Philbrick. I'm a fourth-year student at the Uniformed Services University, and today we're going to be taking a look at the red eye. Now, as you can see from the Will's Eye Manual Differential Diagnosis, there's about 50 items on this list. There are many things that could cause a patient to have a red eye and come in to see you. Now, we're not going to cover everything in depth this morning, but we will try to take a look at the pathophys behind some of the most common causes. We'll also take a look at some of the more dangerous things that you want to make sure you don't miss. And the first thing I'd like to draw your attention to is this chart from the AAFP on dealing with the red eye. And as you can see, if a patient presents with a red eye, the first thing you want to do is ask them about their symptoms. And any patient who's having severe eye pain absolutely warrants an ophthalmology referral. That said, if the patient is not having pain, they're much more likely to have something benign like just a minor dry eye, subconjunctival hemorrhage, or even one of the many types of conjunctivitis, allergic, viral, or bacterial, which tend to be a little bit more serious. All right. What exactly is conjunctivitis? Well, the conjunctiva is a mucosal layer on the inside of the eyelid and on the surface of the eyeball, and when this becomes irritated, there can be increased discharge, crusting, a granular foreign object body sensation. Now, if this has been going on for less than 4 weeks, it's an acute case, and viral conjunctivitis in particular tends to be characterized by itching, burning. It usually occurs in the setting of a recent cold, upper respiratory infection, and it usually moves from one eye to involve both eyes just because of the contagious nature of that infection. Now, the most common cause of viral conjunctivitis is adenovirus, and you should think of a little triad here: pharyngitis, fever, and children. This is who usually gets adenovirus conjunctivitis, and that's the symptoms they usually present with. Now, also be on the lookout for acute hemorrhagic conjunctivitis, which is associated with, well, you guessed it, subconjunctival hemorrhage, of course. This is associated with Coxsackie virus and enterovirus, and usually occurs in more tropical regions. Now, viral conjunctivitis makes the conjunctiva very inflamed, very irritated. It can still look a little bit intimidating, and in viral conjunctivitis, you tend to see follicles on the inferior palpebral conjunctiva. What are follicles? Follicles are accumulations of lymphocytes, which makes sense since that's what our body employs to fight viral infections. And you can see here the fluorescein dye flowing sort of in between the channels of these follicles. That's because in follicles, blood vessels tend to be most prominent around the edges of the follicles. Now, if you find follicles, you should be palpating for a tender preauricular lymph node. This is a great sign that a patient has a viral conjunctivitis. Again, they're usually on the lower lid and vessels around the borders. That's in contrast to papillae. So again, follicles are accumulations of lymphocytes. They're most commonly seen in viral conjunctivitis, and they tend to appear on the lower lid. Papillae are large raised sort of structures that appear in allergic conjunctivitis, and they tend to have vascular tufts or vessel spots in the middle, as opposed to around the borders. Now, the treatment for viral conjunctivitis is usually supportive. Because it's highly contagious, patients should avoid touching their eyes. They can use artificial tears for lubrication, hand washing again to avoid spreading that conjunctivitis from one to both eyes if at all possible. And antihistamine drops may be used to relieve those itching sensations. Now, if a patient develops pseudomembranes, as you can see in this picture here, you may gently want to peel those in the office. And if pseudomembranes are present, a topical steroid may also be employed. That said, there's one type of viral conjunctivitis where you absolutely do not want to use steroids, and that is in a herpes conjunctivitis. The patient may develop these spiculated lesions on the cornea that glow under fluorescein dye, and those are called dendrites. If a patient has dendrites on the cornea, absolutely do not use any kind of topical steroid. They need a topical antiviral, but steroids will make the problem much worse. HSV conjunctivitis can also, of course, affect the conjunctival layers themselves, and the herpes virus can affect the area around the eye as well. Let's move on to allergic conjunctivitis. Now, allergic conjunctivitis is part of a systemic reaction to a systemic allergen, and the symptoms include a boggy conjunctiva, hyperemia, watery or ropey discharge, and of course, itching again. Now, how do we treat it? Well, wait a minute, let's back up and think just a little bit about the pathophysiology, because that will inform our treatment. So when the body is exposed to a systemic allergen initially, it creates IgE against that allergen and kind of wipes it away with no serious reaction. But that IgE hangs around and tends to bind to the Fc receptor on mast cells, and it just sits there waiting. And the next time the body is exposed to that allergen and it binds to the IgE antibody, which is already bound to the Fc receptor on the mast cell degranulates, releasing histamine, heparin, TNF-alpha, and other inflammatory mediators. And that heparin goes on, that histamine goes on to activate further mast cells to degranulate, creating this inflammatory allergic response, which increases vascular permeability, leading to some of the hyperemia and boggy conjunctiva that we see causing the redness in patients with allergic conjunctivitis. So we have a problem with mast cells degranulating, with histamine propagating an allergic reaction, and we have a problem with hyperemia. So how do we treat it? Well, it's a systemic allergic reaction, so we may use systemic medications as well as topical medications just for the eye. And because there's hyperemia, we can certainly employ a vasoconstrictor. And one of the commonly used topical medications for allergic conjunctivitis is actually just a topical alpha agonist. That said, this is really treating, kind of treating the symptoms, and it's not treating the root cause. So if we want to treat the allergy, we can use medications like H1 receptor antagonists, we can also use NSAIDs and mast cell stabilizers. Now, there are worse varieties of allergic conjunctivitis, for example, vernal or atopic conjunctivitis. This is usually associated with seasonal changes, and you might see, in addition to watery discharge, some kind of thick, ropey discharge stretching between the eyelids. But in addition to that, and in addition to the large superior tarsal papillae that may develop, the appearance of an eye with atopic or vernal conjunctivitis may be characterized by the appearance of Horner-Trantis dots around the edge of the cornea. And these are kind of accumulations, they're eosinophilic accumulations around the edges of the cornea. Treatment for atopic conjunctivitis may progress to steroids and immunomodulators, especially if a corneal ulcer develops. Now, there's one more type of allergic conjunctivitis to be aware of for the purposes of boards, and that's giant papillary conjunctivitis. And you can see these giant papillae which have accumulated on the upper eyelid of this patient. Certainly very uncomfortable. They should discontinue contact lens wear immediately and switch over to glasses while this settles down. You should treat it like an allergy. Be on the lookout for any trauma to the cornea. And I just want to draw your attention to the red tufts in the center of these papillae. These are those vascular tufts we were talking about earlier, very visible in the center of the papillae. Now, if a patient develops bacterial conjunctivitis, their picture is going to look a little bit different. They should have less itching, but since it's a bacterial infection, you may see purulent discharge. That's going to be a key feature. Now, the most common offender is going to be different species of staph. But in children, be aware that species of bacteria that commonly cause ear infection may also cause bacterial conjunctivitis. Now, it makes sense if we think about the anatomy. Certainly, the eustachian tube connects the ear to the nasal mucosa. And what else connects to the nasal mucosa? Well, the nasolacrimal duct, which may open farther forward, but there's communication along those mucosal surfaces so that bacteria causing an infection in the ear can migrate up and cause problems for the eye as well. This infection should be treated with topical antibiotic drops. Now, there's one type of bacterial conjunctivitis for which you should be especially careful, and that is gonococcal conjunctivitis. And if you notice especially severe mucopurulent discharge with rapid onset, you should be suspicious of this type of conjunctivitis. Now, in a sexually active adult, you'll want to treat both them and their partner, and treat them not just with azithro, but also with doxy, and you're going to be co-treating for gonorrhea as well as chlamydia. in a newborn in whom severe mucopurulent discharge develops 3 to 5 days after birth, you should be especially careful for gonococcal conjunctivitis. Now, if it's earlier than 3 days, you might be suspicious of a chemical conjunctivitis occurring due to the silver nitrate we put in babies' eyes to prevent bacterial conjunctivitis. And anything after 5 days, you might be thinking about chlamydial conjunctivitis. There are some other causes of conjunctivitis, which is to say irritation of the conjunctiva, and we're going to address them briefly. Superior limbic keratoconjunctivitis is a very interesting sort of conjunctivitis which only seems to affect the superior limbal area on the eye, and it is associated with microtrauma and especially with patients who have had eye surgery. And why is that? Well, if you have a little nip tuck and tighten up your eyelid, you have some increased pressure and increased friction between this top area of the conjunctiva, between your upper eyelid and the surface of the eye here. That increased friction can cause irritation at the conjunctiva. There's also an increased prevalence in patients with thyroid disease, which is really interesting because patients with thyroid disease can develop proptosis, which again leads to increased friction, increased contact, and microtrauma here on the upper limbal surface of the conjunctiva. Now, subconjunctival hemorrhage is usually associated with trauma or pressure, and this is a minor issue that will resolve on its own, even if it looks very severe, as in this case on the right, or if it looks mild like it does here on the left. Symbolferin is the development of sort of membranes and adhesions between the palpebral conge and the bulbar conge, and this is most common in Stevens-Johnson syndrome or toxic epidermal necrolysis. Any patient who has one of these conditions should be seen by an ophthalmologist every day to monitor for eye complications, and patients who have experienced these illnesses in the past are more likely to develop ocular pemphigoid, which is sort of a predisposition to developing these adhesions and blisters on the conjunctiva. Now, there are things besides conjunctivitis or irritation of the conjunctiva that can cause a red eye, and we're going to address some of those quickly. Ectropion is a condition that elderly patients usually develop, and it usually results from sagging and loss of elasticity on the lower eyelid, which as it begins to sag down exposes the conjunctiva to dryness and irritation. This can be taped up in office, and sometimes it needs to be surgically addressed to tighten up the eyelid so that the patient's eye can stay lubricated and stay protected. Entropion is a condition in which the upper eyelid starts to sort of involute, and as it begins to press inwards, the eyelashes, of course, irritate the conjunctiva. This can be taped up in the office for immediate relief, but it often requires surgical intervention. Trichiasis is a condition in which the eyelashes begin growing in the wrong direction and irritate the conjunctiva. These need to be removed, and your options for removal will vary depending on how many eyelashes are growing inward and how they respond and whether they grow back after you initially take them off. Dystichiasis is similar, but just a little different. Usually eyelashes should grow anterior to the tarsus here, to this gray line, and meibomian glands behind the gray line produce oils that help protect the eye. Well, if eyelashes start growing out of this area behind the tarsus, they frequently irritate the conjunctiva, and that's called dystichiasis. These lashes need to be removed as well. Floppy eyelid syndrome is a condition associated with obesity and obstructive sleep apnea, and it's a problem with the tarsus itself. Now, if this fibrous tissue in the tarsus becomes fatty and loses its strength and fibrous nature, it's very easy for this to flop up or sort of be pulled up while the patient is sleeping at night. Just like ectropion, which we talked about earlier, in floppy eyelid syndrome, the conjunctiva becomes exposed and can allow the eye to get dried out and irritated. Canaliculitis is a condition in which the nasolacrimal duct becomes obstructed and irritated, and if you can clear that obstruction, the patient will usually recover. Dacrocystitis refers to an infection of the lacrimal gland, and this is a much more serious condition because the lacrimal gland is behind the eyelids, and dacrocystitis may lead to orbital cellulitis. So here you can see in an MRI a normal lacrimal gland and the inflamed infected lacrimal gland. This condition does warrant antibiotics and sometimes even admission. Preseptal cellulitis is simply an infection of, the simple way to describe it is an infection of the eyelid tissue. It may look intimidating, the eyes will look red and swollen, but it does not warrant a hospital admission. It can be treated with antibiotics. Orbital cellulitis, on the other hand, does warrant hospital admission, and in any patient with proptosis, pain with eye movement, and restricted motility, you should be very suspicious of this. They should be admitted and started on broad-spectrum antibiotics, as this can be a vision-threatening condition. Also be on the lookout for tumors in the eye. They range from classic appearing pearly lesions like basal cell carcinomas to squamous cell carcinomas, which, while they're usually ulcerated on the skin, when they invade or appear on the conjunctiva, they may have this spongy appearance like you see in these photos. Ocular melanoma can invade the sclera. It can also appear on the iris. Keep on the lookout for those. Achalazion is a chronic granulomatous accumulation, which usually forms after an acute stye or hordeolum, which is an infection in the eyelid, has resolved. Blepharitis refers to inflammation and disturbance of the eyelashes. It's usually associated with staph, and you can usually see little collarettes of debris on the eyelashes. Meibomitis is inflammation of the oil glands that are posterior to this tarsus. Pediculosis, that's just a fancy word for lice, and yes, you can get them on the eyelashes too. And acne rosacea is a form of acne that may also irritate the area around the eyes and cause the eyes to be red. There are corneal causes of the red eye, including keratitis, and you might be wondering why we're talking about something as rare as keratitis. Well, we're going to address it because many parents are neglecting to vaccinate their children, and if their children develop measles as a result of missing out on their vaccines, that measles virus can invade the cornea and cause irritation of the cornea itself. It can lead to ulcers, and should you see any patient with measles, you should start them on oral vitamin A. That has been shown to improve morbidity and mortality, and specifically to improve visual outcomes. Anterior uveitis is, of course, associated with HLA-B27 problems and associated with other inflammatory conditions. This may be detected by noticing ciliary flush or lots of injected red blood vessels around the edge of the cornea. You might also notice flare, which is a hazy appearance of the aqueous humor inside the cornea, which is taken on because of all the protein in the aqueous humor. You might also actually be able to see inflammatory cells floating in the aqueous humor under bright light. If you look at the cornea from the side, you can sometimes see keratitic precipitates, which are accumulations of inflammatory cells on the corneal endothelial surface. Carotid cavernous fistula can be diagnosed by its classic corkscrew blood vessel appearance. You can see all these vessels down here. This is the result of a fistula between the carotid artery and the cavernous sinus. Usually the internal carotid, as it traverses the cavernous sinus, if it develops a fistula, will allow more blood to flow out into the cavernous sinus. This, because of the higher pressure of the internal carotid artery, raises pressure in the cavernous sinus, and as pressure goes up in the cavernous sinus, the veins trying to drain from the eye cannot drain properly, and as they back up and become engorged with blood, they take on this corkscrew appearance. Always be careful to check for foreign bodies on patients, especially who have foreign body sensations. That can cause a red eye. A UV or chemical burn can lead to a red eye as well. And be aware that the sclera itself may become inflamed in the setting of connective tissue diseases like Wegener's rheumatoid or lupus. Hyphema is usually the result of trauma. It's an accumulation of blood sitting in the bottom of the anterior chamber, and it does warrant referral to an ophthalmologist. Angle closure glaucoma. Acute angle closure glaucoma is the last thing we're going to talk about today, and I want you to be intimately familiar with the presenting details of that. First of all, a patient can have nausea and vomiting. They will have a painful red eye. They will often have hazy vision, and they will have increased intraocular pressure. Even if you can't take their pressure, you may feel just by tapping the surface of the cornea with a glove finger that the cornea feels like it is rock hard. What is the pathophysiology of this disease? Well, uveal tissue produces aqueous humor, which travels to the anterior chamber and drains through the trabecular meshwork and the canal of Schlemm. And this area where aqueous humor drains is colloquially called the angle. If the angle becomes closed for any reason and aqueous humor cannot escape, it builds up in the anterior chamber, increasing pressure, causing damage to corneal endothelium, and it can be a vision-threatening condition. So it's very important to treat this as soon as you see it. You can start with topical beta blockers and things like carbonic anhydrase inhibitors such as acetazolamide to decrease aqueous humor production and reduce pressure in the anterior chamber. However, if medications fail, we sometimes need to move to a small surgical procedure called a laser iridotomy, where we cut a small hole in the iris, which allows aqueous humor to travel out of the anterior chamber, relieving that elevated pressure in the anterior chamber. This concludes our brief discussion of some of the causes of the red eye. Thank you for listening. And before we conclude, I just want to briefly review everything we've talked about. So we talked about the most common causes of a red eye, viral and allergic conjunctivitis, but we also talked about many other things. And how are you going to keep them all straight? Well, first of all, remember that when a patient comes in, you're going to ask them about their symptoms. You're going to find out whether they're having eye pain. And then you're just going to take a careful look at their eye. You're going to take a look at the eyelids and eyelashes, since there are multiple causes of irritation to these structures that can cause a patient to have a red eye. Then you're going to take a look at the conjunctiva itself. You're going to pull that eyelid back and take a look at the lacrimal glands. You'll look at the sclera, at the cornea and the anterior chamber carefully. And what I'm trying to get at by describing all these things is that many people say ophthalmology feels like a black box, or that it's confusing and it's totally different than everything else out there. But the truth is, even when you encounter something like a red eye that might look intimidating, if you fall back on your history and physical, you ask your patient about their symptoms, and you take a careful look at the different structures in the eye, you will almost certainly be able to figure out what's going on. All right, I would love to answer any questions. If you have them, please write to me, samuel.philbrick@usis.edu. Thanks for your time. Bye-bye.